Okay, folks, here we are again, ASH 2023 in the beautiful city of San Diego, talking with Dr. Spiegel from University of Miami. So tell us a little bit what you focus on in Miami, aside from going to the beach every day, of course.
That's right. That's where I spend most of my time.
Yeah, exactly.
So I'm a hematologist in the transplant and cellular therapy division, and I do cellular therapy primarily for lymphomas, but also do some allotransplantation as well.
And when you're not on the beach, your research is more clinical or lab-based, or?
Yeah, so I do both clinical and translational research. So I did fellowship at Stanford under David Miklos, and that's kind of where I got in the passion for CAR-T and, first in human clinical trials with novel CAR-T constructs, but also looking at CAR expansion, why there are reasons for CAR failure, like antigen loss was a particular focus of mine when I was there.
It's really amazing. I mean, I think CAR-T, we can both agree, really transformed how we take care of patients. It's like a completely new field. Just a few years back, there wasn't much CAR-T at ASH, and now is our sessions on it. But you're presenting really interesting data on behalf of the CAR-T Consortium. Tell us a little bit about the consortium. How is that formed? Like, who's in it, and what's the mission of it? And then let's go over what you're presenting.
Sure. So the consortium is made up of 17 academic centers, and we formed right before ASH of 2019, and I think the real interest was trying to get an early sense of how CAR-T was faring in the standard of care setting. And CIBMTR was obviously going to take some time to accumulate data, and so we really wanted to get out there in terms of how patients are doing.
So you collect data in the 17 sites prospectively? And
yes. We did, it was a retrospective study. We collected 298 patients that were apheresed for intention of standard of care axi-cel, and we followed that patient population now for over 5 years.
So what are you sharing with us at this point?
Yeah, so we're able to share the 5-year data, and I think one of the first things is that the outcomes as far as time to event are similar to that of Zuma 1. So the 5-year overall survival is about 40%. The progression-free survival is 29%, which again is similar to that of Zuma 1, even though 43% of these patients had Zuma 1 ineligibility criteria. So either ECOG status or some medical comorbidities like poor renal function, etc.
How many?
43% of patients. Yeah.
That's big. I mean, that's were you surprised that patients in the real world kind of did similar to trials?
Yeah, I think that's kind of one of the more interesting things that we found, and I think reassuring that we were able to deliver pretty similar results to the clinical trial. I mean, I think that's one of the main things that we talk about the reproducibility of clinical trials. So I think that's kind of our top line message that we're trying to get out there.
Toxicities, did you see anything in toxicities that is worth noting differently?
Yeah, I think as far as the CRS and neurotoxicity, it was very similar to that of Zuma 1 and other clinical trials, even though we did use more tocilizumab and steroids, so I think that's an interesting finding that has been, I think, reproduced across other cohorts as well. But as far as what we're presenting here from the 5-year data, some more long-term outcome data, so there's some interesting things. Our non-relapse mortality was 16.5%, which I think, is an interesting finding to highlight, an important finding to highlight. It was primarily infection was the primary cause of death, even at some later time points from the non-relapse mortality perspective.
That is high, 16%.
Yeah, I think, so I think that's a good question. We were looking at old auto transplant studies, so one of our colleagues in the consortium is Brian Hill. He has an old paper from looking at sort of the actuarial life tables for patients with large cell after auto transplant, and they still had a higher risk of death. Even, this was a 2011 paper, and the non-relapse mortality was almost 10%. So the question as to whether this is higher driven by CAR-T or is it really just large cell lymphoma patients have a higher risk of death. They were all heavily pretreated, and this is not something that's purely CAR driven, but more in terms of the patients that we were treating.
And for viewers, just kind of a reminder, the Zuma 1 was this trial looking mainly at relapsed diffuse large B-cell lymphoma.
This is, relapsed diffuse large B-cell lymphoma having received at least 2 lines of therapy.
So it's impossible for me not to ask you this, but as I'm listening to you, I have to think through, right? Because I'm thinking Do you think that type of data is reproducible with other CAR-T constructs, or do you need to go back and look at them? And do you think it's reproducible in non-DLBCL? Because as you and I know that some of the CAR-Ts have other indications, or is your sense that this is specific for axi-cel, specific for DLBCL, and I must investigate that in others?
So in our session on Monday afternoon, there actually are going to be some real-world data from ide-cel and multiple myeloma. My colleague Mike Jane is leading a consortium looking at Tecartus or Brexu-cel in patients with mantle cell lymphoma. And I would say I think the generalizable things that we see across these is that the outcomes look relatively similar to that of the clinical trials, even though patients have more comorbidities. But some of the important things we're seeing about patient management in the longer term, I think, is generalizable. I think as a field we have to look harder at how we're preventing infection, how we're going to improve on non-relapse mortality, because I think we've really sort of shifted the goalposts. Before, if you look at Scholar 1, median overall survival is 6 months, maybe a 10% tail, and now we're looking at patients surviving longer, and we really have to now that we can put patients into complete remission, we have to make sure that they don't get something else. And it's sort of, I think, changed the paradigm on how we're approaching these patients.
Anything else in terms of like what you'll be working on in the next couple of years from this? I mean, how to put this in context of additional research you're doing?
Yeah, so I think one of the things we're doing is we're going to look at patients in the second line, because a lot of the things that we saw, such as I didn't even mention, we had secondary malignancies, we had 5% of patients getting therapy-related myeloid neoplasms. So, these are all patients getting cyclophosphamide, platinum, etoposide. If CAR-T is brought earlier, are we going to see the same NRM? Are we going to see the same myeloid malignancy? So I think that's really an area of interest. But another thing I think it highlights is, a PFS of 30%, it's still not good enough, right? So, some of the things that we're doing at our center, we have an investigator-initiated trial combining bispecifics polatuzumab with CAR-T. So I sort of think of it as more like a total therapy approach.
I'm thinking of it.
Yeah. My colleague, Dr. Lakakis, wrote this. I think it's very much in keeping with his approach to treatment. He really wants to give the biggest shot up front. But I think that'll be really interesting to see. Are we able to improve outcomes in patients with high burden who are the highest risk?
I think we're very interested in the secondary neoplasms. That's for a different conversation, but it's certainly an important signal to look at.
Absolutely.
And, well, Jay, thank you so much for stopping by, and thank you, and have an amazing rest of the meeting.
Thank you for having me.
Thank you.